Welcome to the new Ortho Info podcast, a monthly series where board-certified orthopedic surgeons provide in-depth answers to frequently asked questions about bone and joint conditions, treatments, injury prevention, and more.
Welcome to the Ortho Info podcast. I'm Dr. Julie Adams. I'm an orthopedic hand surgeon and trauma surgeon and the deputy editor of Ortho Info. Each episode of the Ortho Info podcast answers a question that we hear from our patients. And this episode specifically deals with the concept of fragility fractures, something that we see a lot of in orthopedic trauma and orthopedic hand surgery. Joining me today to help us learn more about this concept is my colleague, Dr. Lisa Canada, who is an orthopedic trauma surgeon at Novant Health in Charlotte, North Carolina, and professor of orthopedic surgery at the University of North Carolina, Charlotte campus. Dr. Canada, welcome to the Ortho Info podcast.
Thank you for having me. This is a great event.
Well, Dr. Canada, I'd like to start by asking you about your background and what led you to become an orthopedic trauma surgeon.
Well, very interesting. I'm not your traditional orthopedic surgeon trainee. I started as an athletic trainer working with injured athletes, and I was like working with orthopedic surgeons and said, hey, I want to be one. So after working for several years as an athletic trainer, I went back to medical school, and I went to medical school at the University of Maryland, and that's where shock trauma was. So when I was a medical student, I knew I wanted to come back and be an orthopedic trauma surgeon. So I did my residency in Cleveland and came back as an orthopedic trauma fellow at Shock Trauma, and now I've been a practicing trauma surgeon for 25 years.
Oh, that's great. Today's podcast is about fragility fractures. And I know that you see many of these fractures in your practice as an orthopedic trauma surgeon. Tell me what the patient's first point of contact is with an orthopedic trauma surgeon.
Unfortunately, I always tell people my calling card is you break it, I fix it. And it usually means they broke their bones. So whether it's most often in the elderly, it's a ground level fall. And it can be the wrist, it can be the proximal humerus or the hip. But those are the most common fractures I deal with in the geriatric population. And fragility, the first sign of a fragility fracture.
A fragility fracture sounds a little scary sometimes to patients. Let's start by explaining to our listeners what that really means when a doctor says those words to them. In the simplest possible terms, what is a fragility fracture?
A fragility fracture is often something that comes from a ground level fall, something that a young person could fall and bounce right back up, but a person who is older or a person that might not have the good bone quality doesn't bounce right back up because something broke. It's a sign that your bones are weak, and it's scary when we tell someone that they just fell standing up. And sometimes people develop compression fractures in the spine, and that's just from wear and tear because their bone can't handle the load that's placed on it.
You've given us a couple of examples of body parts like the proximal humerus, the wrist, the hip, the spine, compression fractures. How is a fragility fracture different than other types of fractures?
So a fragility fracture happens when it doesn't take as much energy for the break to occur. It's a sign of the weakness of the bone. Oftentimes we expect fractures in a motor vehicle collision, or someone walking across the street and hit by a car, or someone that wrecks their bike and flips. We expect that mechanism, high energy, but when you just have a low energy, we define that as you're just standing and you fall and it breaks, or step off a curb and trip and you break your bone. So that's the scary part because they weren't expecting something to happen. And it could come from balance issues, could come from medications, they get dizzy and fall, could come from walking in the night to the bathroom.
Dr. Canada, you and I take care of patients, and as orthopedic surgeons, we love talking to them about their bone health. And in this particular diagnosis, fragility fractures are more than just the broken bone. It's also about the patient's bone health issues. And can you share with our listeners why and what we as orthopedic surgeons and the medical team does to help our patients get better, not just from the broken bone, but from their underlying bone issues?
Right, I think it's important that we as orthopedic surgeons educate our patients and their families about why this happened. And, a fall might not cause a break in everyone's bone, but we got to see what are the underlying factors. Postmenopausal women is the most common group that these falls occur in and lead to fractures, but it could be medications that they're on. It could be habits that they had, such as excess smoking and drinking, or such as their diet. Bone health affects you every day of your life, and you're building into a bank that you have when you're young, and when you're older you forget about that bank, and you still need to build into that bank by exercise, by vitamin D and calcium. And then when you're postmenopausal, you need to talk about it when you're perimenopausal or going through menopause. We need to start talking to our patients then. But oftentimes, again, as trauma surgeons, we only see them after the fact. So we need to educate them as to the cause.
That's great, Dr. Canada. You've outlined some of the challenges that patients may have. Their bone quality declines with age, and it's unfortunately universal truth. And you've outlined some of the things that contribute to bone loss, different medications that can interfere with bone metabolism, habits like smoking and alcohol, not only drinking the alcohol, but also the risk factor that they might get unbalanced and then can fall. And the patient's environment, dealing with patients who are dizzy, helping correct those problems, or rugs that they could trip over. That's really wonderful, and I think that outlining those issues for our listeners is really great so that they and their families can understand some issues associated with these types of fractures. But are fragility fractures only a concern for older adults? You mentioned sometimes children, it's important to talk about bone health. Can you share some information about that to our listeners?
Yeah, it's really important, especially in children, because your bone health, your bone, the biggest bank of your bone is built by the time you're in your 20s. And young kids nowadays, different habits, different way of life. They aren't getting outside and exercising, so they aren't getting vitamin D. They're sedentary. Their diet may not be good. The schools try and force a good diet on you, but nowadays the schools want the money from advertising the Coca-Cola and Pepsi products, and when given a choice, I'm going to take that sweet drink versus milk, which I should be drinking. So we need to enforce habits in the young, and also all along when you're in your 20s and 30s, ensure good dietary habits so you get vitamin D and calcium. And sometimes, Australia has a big problem with low bone mineral density or problems in people in their 30s because they wear the highest, 100 SPF, and so they don't get the vitamin D, and vitamin D is essential for the absorption of calcium. So we need to, and also if you live in Michigan versus living in Florida, you have different exposure. So we need to educate everybody so that they understand the importance in the co-relationship between vitamin D and calcium.
If a patient has a fragility fracture, what does that say about their overall medical health and their risk for future fracture?
A fragility fracture, it's really important that we educate the patient and their family that once they have one fragility fracture, their risk doubles of having another one in the very near future. And overall, I tell people that this is so important because one fragility fracture can lead to another, and it can lead to decline in lifestyle. It can cause you to become more sedentary, which means you aren't getting exercise, and thus your vitamin D and calcium levels, your bone health is failing even more. It can lead to loss of independence, and ultimately it can lead to loss of life. So I tell people this is something we don't want, the second fracture. So the biggest thing when I have a patient that comes in, I don't want to see them for their second fracture. As much as I love operating and taking care of fractures, we want to educate them so that they can continue to be independent and lead a healthy life and be active and be present for their family. So that's what I try and frame it as.
That's great. Dr. Canada, you've outlined many of these patients are older patients, and they may fall from a ground level height and have a hip fracture or some other fracture. How do doctors decide who needs surgery, what surgery, and many of these patients may have other medical issues? What does that look like?
So often, this is a great question. I think it's really important, just because there's a broken bone doesn't mean we have to do surgery. It depends on what the fracture is, what their underlying health is, what their mental status is, and if they're in pain. For the most part, let's just look at hip fractures, for example. Hip fractures, for the most part, the majority do get operated on. However, there are some people who might have metastatic cancer, some people who are demented, and some people, that's why I look at the patient and examine them, and I always want to meet their family or talk to them if they aren't able to be there. Because if I examine a patient and they aren't in pain, then it's not worth operating on. But always make sure we call it a shared decision making, so that I present both sides, the positive and the negative. And the other thing is, we have to realize wrist fractures and proximal and shoulder fractures, for the audience, wrist and shoulder fractures don't need surgery when you're 65 and older. Not all of them do. In fact, in those, the majority can be treated through different means, as long as we line it up good and it's appropriate for that. Some you have no choice, but for the most part, you want to look at them and discuss the treatment options and what the end result will be. Because in 1 year, am I going to make you better by doing surgery, or am I increasing your risk of having complications? You know, especially in the shoulder, that bone is so porous. Putting certain types of fixation in just might not be the best thing.
That's great. Having a shared decision making with the patient, with their family, looking at the global picture about their health, their goals, and their other medical risk factors is very important. Does poor bone quality affect what you do surgically and how you fix it and how the fracture will heal?
Oh, definitely. That was a great question. Poor bone quality comes into our decision-making process, into what type of fixation we can do. And also, one thing, this bone is covered by skin, and we have to think about that, because oftentimes elderly patients might be on those medications, their skin is more thin, they might have bad bruising, and we also have to make sure, if we are doing an open procedure where we are making incisions, that the skin will allow us. So the first thing I always do is look at the skin, and not just of where they break, but across their body. And also look at their circulation. Are they retaining fluids? So this is all important to come into the decision-making process. And then when it comes time to fixing it, you know, we're talking about eggshell bone. And there are different types of plates and screws that can be used. They give you better control and better securing of the bone. There's other times where if we just use our conventional fixation that we use in a 16-year-old healthy male, that it will just fall apart. So we have to think about the covering of the bone quality, and using the different screws and plate configurations that give us the best chance for a good outcome.
That's great. I think that many times a patient has the fracture, and we focus very carefully on treating the fracture, whether with surgery or non-operative means. But after surgery and in the quality of their recovery, we often address the underlying bone metabolic issues, and usually that's with a team-based approach. Can you tell me what kind of investigations a patient might expect to have, whether that be balance or a lab test or x-rays, to help guide their treatment after they've had a fragility fracture?
Yes, after they have a fracture, we want to be like detectives and figure out why. And can medications be changed? Do we need to send them back to their primary care? Because certain medications, even your medications for stomach problems, can interfere with your calcium and vitamin D. So we need to, look closely at their medications. We need to talk to them about their habits. We need to look at their lab values. It's very important. We always get vitamin D and calcium, but we also get other labs that are associated with bone health. We do a full workup, and we also want to learn about their social situation at home, because food hunger is real in the elderly, and not having access to healthy food and meals can be an issue. And so we do labs not only for vitamin D and calcium and other factors that contribute to your bone health. We also do nutrition labs, because we want to know what your nutrition is, what your protein is, if you have the capacity to heal this fracture, and what we need to do to augment it. And then we also talk about, once they get out, how do we evaluate? Have they had a DEXA scan? A DEXA scan evaluates the bone mineral density of your spine and hip, and it gives you an idea of your bone health and what level of treatment you need, because then there are different levels as to whether you have osteoporosis, which is full on, we need to treat you with your bone, or osteopenia, which means your bone is weaker and more brittle and heading towards there, and we gotta also have a approach for that.
That's great. I think of care of many of these patients as a team sport, and you've mentioned patients' primary care doctors. You've talked about physical therapy and environmental assessments and making sure patients are safe to walk, that their balance is okay. Many times a patient will come in and see us, but then if the bone density test that we obtain or their primary obtains demonstrates osteoporosis, who do they go and see for that?
So that's a great question, because it depends on the resources available in your area. If you're in a rural area, some of the states, Montana, Wyoming and such, that can be very difficult to have access and also to drive the distances. So sometimes your primary care is the main person that will address it. Sometimes it is the orthopedic surgeon, because patients love listening to us. They trust us. They trusted us to fix their fracture, but we aren't comfortable dispensing all of the medicine. So at the minimum, we start patients on vitamin D and calcium. And depending on their age, in the early postmenopausal phase, we might send them to their OBGYN to talk about hormone replacement therapy, which is becoming increasingly more popular and common because the levels of the estrogen and progesterone do not lead to the cancers. They're given at such low dosages, but estrogen is so important in bone health. So that's another possible alternative. Also an endocrinologist. If they have severe osteoporosis, we need to prevent the next fracture, and some of the medications that can be given are best given by them.
That's great. Yes, I think that for our listeners, it's really wonderful to have so many different specialists that we can pull information from and share information with as we take care of some of these patients. Also for our listeners, I think that if they're listening and they say, gosh, fragility fracture, I don't want one of those. What's your advice to them about some impactful things they can do in their life today at 20, 30, 40 years old or 80 years old to help prevent a fragility fracture?
A few things are important. And my mom, I will give an example of my mom who's 90. She wants to maintain her balance and not fall and get a hip fracture. Maybe because her daughter is an orthopedic surgeon, she hears me talking about it. She actually asks for exercises. So we'll get started when you're in your 20s and 30s. It's important to avoid bad habits such as smoking, excess alcohol, and also excess sodas, which can deplete the calcium. A diet that consists of vitamin D and calcium in some form, and people don't realize all the different forms that you can get of vitamin D and calcium. Obviously, milk is great, but there's many other ways to get your calcium. Calcium is in orange juice, for example. You can get calcium through dietary food, and then supplementation. Weight-bearing exercise. That's what we're going to talk about first, weight-bearing. Just 30 minutes of exercise 3 days a week is what we want. And I tell someone older, they're like, how can I do that? Just start with walking to your mailbox or walking around the house. And then if they say their joints are sore, then we try and get them on a stationary bike or another form of exercise. Being active with golf. And in the nursing homes, they have some fun. Exercising with the video games is actually a form of exercise. So just being active and up and about, vitamin D and calcium minimum, good habits, what can you change to be better?
That's wonderful. On that note, Dr. Canada, it's time to wrap up this OrthoInfo podcast. And thank you, and thanks to our listeners for joining us today.
Thank you for the opportunity.
This has been the Ortho Info Podcast, brought to you by the American Academy of Orthopedic Surgeons. Production and editing by MK Quinn Media. You can find the Ortho Info Podcast on orthoinfo.org and wherever you get your podcasts. Like and subscribe so you won't miss new episodes, and visit the Ortho Info YouTube channel for full video podcast episodes and shorts. The views and opinions expressed by guests are their own, and their appearance on the podcast does not imply an endorsement of them or any entity they represent by the AAOS. Reference to any specific product, device, or service during this podcast is for educational purposes only and does not constitute endorsement or recommendation by the AAOS. Ortho Info, expert musculoskeletal health information provided by surgeons, trusted by patients.